Anytime we talk about atrial fibrillation burden and stroke, especially in an outpatient setting, the one trial that's brought up the most is what's called the ASSERT trial from New England Journal in 2012. Again, these are over 2,500 patients that had pacemakers or ICDs or some rhythm monitoring capability continuous. And they took patients over 2.5 years and eventually divided them in half. Those who had more than at least a 1 6-minute episode of atrial high rate episode or likely atrial fibrillation, and those who didn't have a 6-minute episode of an atrial high rate episode. And if you follow them over 2.5 years, those who had 6 minutes or more had a 1.7% thromboembolic risk, and those who had less had a 0.7% thromboembolic risk. So if you take the group of patients had atrial fibrillation for at least 1 6-minute episode, and you divide them into those who had a longest episode of 17 hours or more and those who did not have such a long episode, you're talking about a 4.9% thromboembolic risk in the former group and 1.2% thromboembolic risk in the latter group. So if you can imagine a patient that's on a medicine service that develops 15 minutes of atrial fibrillation, you're like, I don't know, if a CHADS to vascular 2 or 3, the guidelines say anticoagulate, and you put a heart monitor, a 2-week or 4-week continuous heart monitor on, and then they have a 19-hour run of atrial fibrillation, whether it be symptomatic or not. I think then you really have some ammunition there with the patient to say, I think we're at the point now where the scales are tipping toward anticoagulation. That being said, if you have someone with a 2-week monitor that shows none or zero, I still think the jury's out, and sometimes we repeat 2-week monitors. We'll repeat in another 6 months, and we explain to the patients the risks of not moving forward with anticoagulation because strokes from AF, as we all know, can be debilitating. And yet some patients really don't want to take extra medication if they don't feel the doctor feels it's 100% necessary. So we have those conversations in cardiology clinic with patients all the time.
Atrial fibrillation that lasts less than 48 hours after acute stressor. Do you tend to think about those patients in a different sort of bucket than your atrial fibrillation? That maybe they're not having long episodes, maybe it's intermittent episodes throughout the hospitalization. Is that a meaningful difference, or is it sort of hard to know what to do with that?
That 48-hour rule has been around and it's somewhat arbitrary, honestly. I don't think anyone knows or anyone says they know what the best cutoffs are. You have to kind of question that. I look at it in three buckets. I look at it in minimal, so we're talking 5 6 minutes or less. And then I think of someone that had a longest sustained episode, 5 to 17 hours. And then anything more than that, I think you have in the hospital is a pretty substantial burden of atrial fibrillation. And if you're in that indeterminate, um, that CHADS 2 vascular that just reaches a threshold, if you're over 12, 17 hours straight of atrial fibrillation, I think your stroke risk may be a little higher, but the likelihood of it returning is higher also. The 48-hour rule is not something that, we typically abide by frequently. From the little data that we have, the number of episodes is not as relevant as the longest duration of a single episode or the cumulative time in atrial fibrillation of all the episodes combined. But what I lean toward most, and it's also like the easiest to use, would just be what is the longest episode that someone had. If someone had one 15-minute run versus someone else who had 7 15-minute runs of atrial fibrillation, I would assume that the latter person's at higher risk. But I look at someone who had one 9-hour run of atrial fibrillation as, I pay a little bit more attention to that than someone who had 4 10-minute runs. But it's hard to know.